Right. So you have seen many wonderful videos, and I will just show a few things which we thought of right in the beginning and were innovations. Some of these you have already seen. Uh, the simplest of the things is the ability to make these sutures. Now, when we started GATT, we had these sutures available, but then the pandemic struck, and there was a time when you didn't have these sutures. And this is something that one of our nurses thought of, and then we worked upon. You just need to heat a cyclodialysis spatula or an iris repositor with any heat source that you have. It can even be a candle, a cigarette lighter. So we have one in the OR now, and everybody who comes in keeps asking, "Why do you have this in the OR? Who smokes inside the OR?" So you can just do it. What is very important, and we learned now, that you make one side of the tape smaller and the other side a little bigger. So using a 6-0 Prolene, if you do that, the angles are all different, eyes are all different, and so is the Schlem's canal. Sometimes with the same size of the umbrella tape, you'll not be able to go through, and sometimes it starts passing in very easily when you can get a false passage. So we have a normal size tip on one side and a small tip on the one side, so that if you face too much resistance, you can actually go and use the smaller tip. The next thing was using the measure app, because you have to tilt the microscope to a particular angle, and not just uh, not just for the sake of accuracy, but it really works in the terms of ease. If you have a measured angle and then you put a mark on the microscope exactly at that point. Okay, the mark is not seen here in the video, but if you put a mark exactly alignment, then you can, anyone, even the technician, can just rotate and tilt the microscope to that angle, and then you can do it hands free. The other thing was, when I was starting off, was the problem with bleeds. Now you can have bleeds any time in GATT. If you are When you are making the goniotomy after phaco or before phaco, when you are passing the suture, when you are ripping the suture, and when you are starting, you take time, and the more time you spend inside the eye, more will be the bleed that you get. So it was coming in the way of me learning this procedure. So the normal thought process was to go inject viscoelastic, wash off the thing, but that was again taking a lot more time, and the nurses were not happy to go to the store again, get another bottle of orogel. The store people were not happy, and I had to sign a paper on why I'm asking for 4 orogels for a single GATT, which should take 5 minutes to finish. So I thought, this is enough, and my old friend from SICS days, the ACM, came into picture. If you have a bleed, use an anterior chamber maintainer. If the moment you put an anterior chamber and you aspirate whatever blood is in the anterior chamber, you will not have any blood interfering with your view during the entire surgery. And once you clear it, you will have a blood free experience till the end of surgery. But remember that it is because that the ACM is continuously washing off the blood. It's not because there is no bleeding happening. So at the end of the surgery, you have to inject viscoelastic if you use an anterior chamber maintainer, and leave, as Dr. Ganesh said, 35 to 40% of orogel. Also very important is that you stick to one viscoelastic. So we have different packages in our institute. In one package we get only HPMC. There is another package where we get orogel, another package where we get Helon, another package where you have viscoat right there. And it was becoming difficult, because I found out that in premium packages I was getting very high IOPs on day one. That was because the amount of orogel that you have to leave is different from the amount of Helon that you have to leave. So stick to one thing, or with time you can titrate the amount of viscoelastic that you have to leave. I stick to just one thing for all surgeries when I do GAT. You just need, I just use Orogel and I leave the amount of viscoelastic that would normally be beyond a rhexis margin. So imagine a rhexis in the central axis, and whatever is supposed to be the edge of the rhexis, leave all viscoelastic beyond it. Another interesting thing that we tried and tried successfully was, because I go to rural centers also at my institute, and there you don't have microscopes that you can tilt. So you were trying to see how can we do this there, because a big problem in those centers is they're not there. If I do a trabeculectomy, everyone who has done a trab will know, everyone who has a child will know that the way you can take care of your own child, nobody else will do it. The way you can take care of your trabeculectomy, massaging, releasing the suture, teaching the patient how to massage, increasing, decreasing steroids, giving 5-FE injections, no one else will do it. So that is very difficult. So GATT gives you liberty from that fact, that you don't need to do all these interventions in the post-operative period. You cannot also do. So there's no option of doing it, and that's a freedom from responsibility. So in order to do that, we were thinking of something, and this is what we came up with. So we have a view here. You see this, look at this view. This kind of view, you see almost 120 degrees of the angle here. And the detail at which you can see this is amazing. Can you imagine what gonioscope is being used? It's not a gonioscope. It's a nasal endoscope that we are using outside the eye. And this is amazing, because this was difficult to do because there was one person who had to hold the endoscope. So I had Javed Ali, our wonderful oculoplasty surgeon, who was doing it for me. And this is the kind of view that you can get from the endoscope. And this gives you freedom from the tilting of the microscope. Even if you don't have a microscope that has the ability to tilt, you can still do this, and it saves you from a lot of things. You don't have to sit so far away from the microscope. You don't need the microscope at all. You're seeing it on a screen. So imagine the change that a retina surgeon has had because of ingenuity, when they had to put all those inverters and biomes and all that, and they're looking straight onto a screen and doing this. So this can give you a lot of independence, and this is what was happening from the microscope end at the same time. So that is what the microscope is seeing, and this is what the endoscope screen is showing. So this is something that can give you independence from tilting, save your neck, because it's very easy to have a false posture when you're sitting so much far away and trying to reach for the eye. The view is great, and the reach that you can have with this is amazing, though the instrument is expensive. Thank you so much. And because we have time in hand, and there was this initial plan to actually circulate a form amongst us, and we will leave 10 minutes for you, sir, right? We have some time in hand, and I just wanted to look at the differences in the practice that we have. And this is the survey that we have, and there's some very interesting things that came up. Traditionally, angle closure is supposed to be a contraindication for GATT, right? But I believe most of us are doing GATT for angle closures. So, Dr. Ganesh, what kind of angle closures would you not do GATT for? Do you have a hand mic here?
I would stick to PACGs in which I can see the angle. There are some PACGs you can still see the angle. They're not zippered and closed. So those are the eyes I would go for.
So even if there are small goniosyne K,
yeah,
and you can see the angle and you have space enough for goniotomy, you will still go ahead.
I would still go ahead, and sometimes you could indent and see. And if I see that more than 50% is getting opened up, I would give it a shot. It shouldn't be a zippered angle. That's one. Like the creeping angle closure ones, which we used to see, they are definite. I wouldn't attempt that.
Great, and GATT works wonderfully well for them. I have 11 patients with 6 months follow-up, angle closures, all of them are working.
Working, the only caveat I would say is they will have qualified success if you have a very strict criteria of less than 15 compared to POAGs. And they sort of in our series they have come up to pressures of 18. We are not treating them, but you don't get the low IOPs in which you can get with POAGs. Or pseudo exfoliation. Pseudo exfoliation does fantastic well.
Absolutely.
Pseudo exfoliation with angle closure also does pretty well if you do it with cataract. But you'll get qualified success. You may not get complete success with the low IOP thresholds.
Great. And one thing that I realized is
on the same hand, they don't have to be on medication.
They don't have to be. They are medication free.
You won't get low.
Can we have another hand mic, please, for the expert panel? So you can do GATT under topical also. Until unless you go behind the ciliary body and you are in the suprachoroidal space, you will not be causing pain. So because I believe the local anesthesia and the injection and massage that you have to give after the procedure is really responsible for the vision loss that you face in TRABs and AGVs and even GATT. So most of the patients who can look at a light, we are doing topical now, and it's possible and very easy to do it. This we have already discussed. And Dr. Ganesh, the 26 gauge that you use is how the normal 26 gauge won't reach the angle, right? So where do you source this from?
We have the normal gauge does reach the angle. Why do you say it doesn't reach the angle?
No, because the one that we have, it doesn't.
No. We use the one which we give subconjunctival injection if you want to.
Okay.
It goes across. It goes across, and I use that.
Okay.
It's a half inch. Yeah.
Which company is that needle from?
Brown. Dispoman only. Honor Dispoman. Yeah.
Okay.
It goes very comfortably. I stopped using MVR because getting everything from the retina department is very difficult. So I tried to have everything within. In fact, sorry, I didn't show the video with the SICS with the.
SICS with.
SICS was one. The other one was using micro forceps. It didn't come up, but you could use a micro forceps. So we abandoned taking anything from retina now. Be self-sufficient as much as possible.
Yeah, and the retina department, they use the disposable Grishaber forceps. You have a metallic titanium version also, which is a little more expensive, but that will last years for you. So we have shifted to that. We are also cutting off from the retina department till you have a nucleus drop. The other interesting thing is the sequence of doing phaco and GATT when you are doing a combined procedure. Dr. Swati, what do you do first, and why that choice?
So first I used to do cataract first because I wanted time for GATT. But then what used to happen, that my wound, the phaco wound used to take away all my viscoelastic away. And again I had to fill my anterior chamber. And suppose if I have a hard cataract and I'll have SK at the tunnel, so half of my cornea will be gone in that, and I'll be struggling to see the angle. You can see, but it will be a little difficult. If you have a virgin cornea which is totally clear, you can have enfast view very nicely. So, and if God forbid you have a nucleus drop, so your chance to do a GATT is gone. And then you struggle with the placing a IOL itself. So better to do one surgery, complete the glaucoma part, go to the the cataract part. That is why I shifted first to now GATT first and then phaco. I initially used to do SICS with GATT also. So that also there also I realized, because in SICS your side port has to be made. Then your side port for the GATT has to be made. So I used to feel, okay, let my one side port take care of everything. But that is not the case. So you have to meticulously plan if you are doing an SICS GATT, where your side port will land up and where your side port for the suture should be. So you should not make so many entries into the cornea just because you want to achieve something. We have to be still safe and give good results to the patient. So I would say first do a GATT, then go with the cataract surgery.
Great. Dr. Mahesh, you have something to add here?
Even before doing GATT, I just do the Rexis so that I don't injure the ALC. Just do the Rexis, then do the GATT. And that advantage that gives that after you place your IOL, you don't have to wash your visco out at the end of your cataract surgery, which will act like your 25% or 30% viscofill that you need to leave behind.
Right. Dr. Ganesh, you do phaco first, right?
I do phaco first. I do finish the phaco first and then do the cat.
Right. Why did, because the global thought and majority thought seems to be, or slightly in majority seems to be doing GATT first. But here we are divided. I also do phaco first. Why don't you do GATT first?
Maybe because now we have started operating, angle closures slightly. So that's one tendency. That could be the reason. So you just get away with the phaco part of it and then concentrate more on the GATT part of it.
Yeah, the view is better.
Better.
The other thing is that I had temporarily shifted to GATT first, but then I came back because there was one patient where I had a bleed, massive bleed, and the entire phaco became very troublesome. So when you have that, if and when that's rare, that the angle keeps bleeding, but then I did 4 5 phaco GATTs with GATT first, and then I shifted to phaco first that way. I'll just end up with
Siddharth, one more thing. After phaco, there is blood in Schlemm's canal invariably. So that used to bleed. So it I think it's surgeon dependent. Whichever you feel confident, you can
yeah.
do.
There's no right way or wrong way about it.
At least Fago can finish fast, then you can take more relax you can do your cat one. One more thing, angle become deeper.
Sir.
Once you do a Fago, view is better and more confident. You don't need to bother about.
Right. The other difference is the kind of steroids that we use and the duration that we give steroids for. Mahesh, what your preference would be in these patients?
I give prednisolone first week 6 times. No, prednisolone 6 times with antibiotics, and after 1 week, based on the hyphema that is remaining, mostly shift over to lotipred, or even sometimes now off late shifted to NSAIDs.
Okay. Okay. I'll just this last point. We have some time in hand. Sir, you can start setting up your thing. We will just talk here.
So in our center, we follow the same IOL post-op regime, 42 days. And unless we have a hyphema, then we can give 2 days intensive steroids like we do for trap. But mostly we follow 42 days regimens, 7 days. No sir. We do get steroid response, but after that, so then I shift to NSAIDs. We get sir, and that steroid response is very rapid, and but normally we get after 4 weeks steroid. But here in GATT, we get after 2 weeks also we can get. Sometimes I blame my orogel leaving inside for that. Sometimes I blame dexamethasone for that. But yes.
Yes. So I don't. I use steroid 4 times a day for 10 days. Then I stop it. I use NSAID for 30 days, 3 times a day, and antibiotic 4 times a day for 30 days. That's all. No steroid after 10 days. All the patients which I showed, there's no steroid going in after 10 days. 10 days. Because why my philosophy changed this, I used to pump in a lot of steroids. Then I found steroid response because I feel the outer wall also reacts to steroid response. So remove the inner wall, so that whole thing is gone. And the other thing is, when you give, you don't, and you're taken the resistance for inflammation to be retained in the eye. The only way inflammation can go is through the trabecular meshwork. So you remove the whole thing. So you're not treating inflammation. You're treating hyphema. Hyphema doesn't require steroids, number one. Number two, hyphema doesn't remain there also if you put oro gel. So there's no inflammation in the eye. So you don't need steroids at all. So use 4 times a day for 10 days and stop. What about you?
The same thing. I use Miticom, Vigadex, or Maxim D, a combination for all my cataracts and GATTs, phaco GATTs. I use it for 10 days and then stop it. So
One patient I started now recently after 3 weeks she came with allergy to NSAID. So even now NSAID, I think I'll stop in very quickly. They don't. Eye is white and quiet. There's no inflammation. They see 6/6. You have to give glasses in 10 days. They do as good as phaco if